Welcome. Today, we're diving into a rare and potentially serious condition known as Petrositis, or Gradenigo's syndrome. This condition, while uncommon, can have significant consequences if left untreated. Join us as we explore its causes, symptoms, diagnosis, and treatment, providing a comprehensive overview of this fascinating but challenging medical enigma. Petrositis, at its core, is typically a complication arising from a middle ear infection, or otitis media. When this infection isn't properly treated, or if it becomes particularly aggressive, it can spread beyond the middle ear cavity and invade the petrous apex. The petrous apex is the bony tip of the temporal bone that houses the middle and inner ear structures. This invasion by infection sets the stage for the development of petrositis. The pathophysiology of petrositis is centered on the spread of infection. Untreated otitis media allows bacteria to migrate from the middle ear into the pneumatized air cells within the petrous apex. This leads to inflammation and eventually bone erosion. This erosion can then affect nearby structures, most critically the trigeminal nerve, abducens nerve, and potentially the inner ear itself, leading to the characteristic triad of symptoms known as Gradenigo's syndrome. Petrositis is considered a rare condition, largely due to the advancements in antibiotic treatment for otitis media. Before the widespread use of antibiotics, it was a more common complication of middle ear infections. While precise epidemiological data is limited due to its rarity, it's more likely to be encountered in areas with limited access to timely and effective medical care for ear infections or in cases of antibiotic-resistant bacterial strains. The classic presentation of petrositis is Gradenigo's triad, comprised of three distinct symptoms. Firstly, there's otitis media, often presenting with ear pain, drainage, and hearing loss. Secondly, abducens nerve palsy manifests as diplopia or double vision, due to weakness in the lateral rectus muscle. Finally, trigeminal neuralgia results in facial pain, typically around the forehead, cheek, or jaw, following the distribution of the trigeminal nerve branches. Diagnosing petrositis requires a high index of suspicion, particularly in patients presenting with the characteristic triad after experiencing or currently having otitis media. A thorough neurological examination is essential to assess cranial nerve function. However, the gold standard for diagnosis is imaging. CT scans of the temporal bone can reveal bony erosion or inflammation in the petrous apex. MRI is also helpful in visualizing soft tissue inflammation and ruling out other potential causes of cranial nerve palsies. While petrositis itself doesn't have different types, in the traditional sense, the severity and extent of the infection can vary. Some cases might be localized to a small area of the petrous apex, while others can involve more extensive bone erosion and greater involvement of surrounding structures. The specific bacterial species involved can also influence the clinical presentation and treatment approach. Treatment for petrositis primarily focuses on eradicating the infection and addressing the complications. Intravenous antibiotics are the cornerstone of therapy, typically broad spectrum initially, and then tailored based on culture results from ear drainage or surgical samples. In many cases, surgical intervention is necessary to drain the infected area and remove any necrotic tissue. This may involve a mastodectomy or other surgical approaches to access the petrous apex. Management also includes pain control for trigeminal neuralgia and supportive care for any neurological deficits. The best way to prevent petrositis is prompt and effective treatment of otitis media. This includes early diagnosis by a healthcare professional and adherence to the prescribed antibiotic regimen. Regular follow-up appointments are crucial to ensure the infection is resolving appropriately, particularly in children. Education on proper ear care and hygiene can also play a role in preventing ear infections in the first place. The prognosis for petrositis depends on the extent of the infection, the timeliness of diagnosis and treatment, and the patient's overall health. Early diagnosis and aggressive treatment with antibiotics and surgery can often lead to a good outcome. However, delayed treatment can result in permanent neurological deficits, such as persistent cranial nerve palsies, or even more serious complications like meningitis or brain abscess. Ongoing research is focused on improving diagnostic techniques and developing more targeted antibiotic therapies to combat antibiotic-resistant infections in the petrous apex. Researchers are also exploring minimally invasive surgical approaches to improve outcomes and reduce recovery time.